Your doctor just told you your blood pressure is perfect, and that might be the most dangerous thing that happened to you this week. You felt it this morning. You swung your legs off the bed, stood up to head to the bathroom, and for just a second, maybe two, the room went sideways. You grabbed the nightstand, waited, it passed. You told yourself it was nothing, just getting older, just moving too fast. But here's what nobody told you, and what I am going to prove to you with hard data in the next few minutes. That moment, that dizzy second, that grab for the nightstand, it's not aging, it's a warning, and there's a very good chance your blood pressure medication is causing it. I'm going to walk you through 5 critical things your doctor isn't telling you about blood pressure after 70. I'm counting them down from 5 to 1, and number 1 is the piece of information that changes everything, the one that could literally save your life or the life of someone you love. By the time we get there, you'll understand why everything you've been told about blood pressure may have been setting you up for the very crisis you're trying to avoid. The research exists. It's been published. It's just not making it into the exam room. I'm Dr. Jane, and I have spent years reviewing cardiovascular research, specifically focused on older adults, not middle-aged adults, not the 45-year-olds most of these big clinical trials were built around. Seniors, people over 70, over 75, over 80, people whose bodies follow completely different rules than the charts in your doctor's office were designed for. I've read the studies that most physicians haven't had time to read. I've looked at the raw data, not just the summaries, and what I've found is deeply troubling and deeply important. There is a gap between what the research now shows and what is happening in doctors' offices across this country every single day. And that gap is costing people their independence, and sometimes their lives. Stay with me. Before we dive in, if you're finding this useful, take 2 seconds right now, hit that subscribe button so you never miss a video, and give this a thumbs up. It genuinely helps more people like you find this content, and drop a comment below. Tell me what country you're watching from. I'd love to know where our community is tuning in from around the world. Hold on a second. Before we go any further, I've put something together for you. It's called the Glucose Paradox. It's a free guide on blood sugar and diabetes, and you can grab it for free through the link in the description. I'm telling you this now because I want you to finish this video with a concrete tool in your hands. To get it right away, just click the link in the description, head over to my site, and drop your email. You'll receive the guide in your inbox a few minutes later. But I don't want to take up any more of your time. Let's get back to the video. Number 5. The symptom your doctor is calling normal aging is actually a red flag. Think about the last time you stood up from your recliner after watching television for an hour. Maybe you pushed yourself up with both hands, got vertical, and then nothing dramatic. Just a moment the edges of your vision went soft, or the room seemed to tilt. Barely. You stood still. You put a hand on the armrest. In 3 or 4 seconds, everything was fine again. You moved on with your day. You've probably mentioned this to your doctor at some point, maybe in passing, at the end of an appointment. And there is a very good chance your doctor said something like, "Oh, that's just orthostatic hypotension. It's common in older adults. Just stand up more slowly," said it calmly. Maybe nodded in a reassuring way. Then moved on to the next item on the checklist. Here's what they didn't say. That moment, that soft-edged dizzy second, is your brain running low on blood. Not permanently, not dangerously, in that single instance. But it means your cardiovascular system is failing to maintain adequate pressure when gravity pulls blood downward as you rise. And if it's happening regularly, if it's a pattern, you are at significantly elevated risk for a fall. Not a stumble. A fall, with a fractured hip, or a broken wrist, or a head injury, with surgery, with weeks in a rehabilitation facility, with the kind of cascading complication that in older adults does not always end in a return to the life you had before. And here is the part that should make you angry. The most common reason this is happening, especially if you are over 70 and on blood pressure medication, is not that your arteries are weak or your heart is failing. It's that your blood pressure is being medicated too low. The target your doctor is chasing, the number they're proud to see on the cuff, is actually producing the problem. That dizzy second is the evidence. That grab for the nightstand is the data. And we are just getting started, because number 4 is where we have to talk about that target directly and why it was never designed for a person of your age. Number 4, the perfect blood pressure number, was built for a 50-year-old, not for you. You've probably heard the number so many times it feels like medical truth. 120/80. Or maybe your doctor says under 130 systolic. It's on every chart, every pamphlet, every health magazine, in every waiting room you've ever sat in. Lower is better. That's the message. Get it down, keep it down, stay down. And for a 50-year-old in good general health, that message is largely correct. The data on middle-aged adults is solid and consistent. Getting blood pressure under control in your 40s and 50s meaningfully reduces the long-term risk of heart attack, stroke, and kidney damage. Nobody disputes that. It's good medicine for the right population, but here is what the guidelines quietly fail to account for. The landmark trials that produced that number, the studies that defined 120/80 as the gold standard, were conducted overwhelmingly in middle-aged populations. When those results came out, and they were impressive results, they were applied universally to 55-year-olds, to 70-year-olds, to 85-year-olds, with multiple chronic conditions and a cabinet full of medications. The assumption, never quite spoken aloud, was that what works for a 50-year-old must also work for an 80-year-old. Same body, older version, same rules, same target number. That assumption is wrong, and the research of the past decade has been quietly, carefully, systematically proving it. A study published in JAMA Internal Medicine, one of the most respected medical journals in the world, followed 15,342 adults over the age of 75, real-world seniors, not hand-picked healthy volunteers, people with diabetes, prior strokes, heart disease, varying levels of frailty. The researchers tracked their average blood pressure over 5 years and then measured what actually happened to them during that time. They divided participants into groups based on systolic pressure, below 120, between 120 and 130, between 130 and 140, between 140 and 150, and above 150. Here is what they found, and I want you to sit with this for a moment before we move on. The group with the lowest mortality rate was not the group below 120. It was the group between 130 and 140. The so-called perfect group, the ones hitting that textbook target of below 120, had a 28% higher risk of serious falls requiring hospitalization. They had higher rates of acute kidney injury, meaning their kidneys couldn't function properly at those lower pressures. And their overall mortality rate was 14% higher than those maintained in the moderate range. 14% more deaths. Not in the high group, in the low group. In the group achieving what the guidelines call success. Lower was not better, lower was worse. The very intervention designed to protect them was increasing the risk of the outcomes it was meant to prevent. That's not a rounding error. That's not a statistical blip. That is a finding that should change how blood pressure is managed in every older adult in this country. And yet the prescription pads are still reaching for 120. This is why I'm here. And this leads us directly to number 3. Because what's happening inside your body after 70 is so different from what was happening at 50 that the same numbers literally mean different things. Number 3. Your arteries after 70 are playing by completely different rules. And your medication doesn't know that. Imagine a garden hose, a brand new one, still coiled, fresh out of the package. When you turn on the faucet and water surges through, it expands slightly under pressure and then snaps back. It flexes, it absorbs. The pressure wave moves through without violence. That's what young, healthy arteries do every single time your heart beats. They expand and recoil. The walls are elastic. The system is self-regulating and forgiving. Now imagine that same hose after 20 years in the sun, stiff, brittle at the bends. When you turn the water on, it doesn't flex anymore, it just transmits. Every bit of pressure from the source travels straight down the line without cushioning. One hard surge, and you can feel the whole thing jump in your hand. That's arteriosclerosis. It's the structural stiffening of your arterial walls that happens with age in virtually every human being. It is not a disease you catch. It is a biological reality of living long enough. And it has enormous implications for what your blood pressure numbers mean. Implications that the standard guidelines were not built to handle. When your arteries are stiff, your heart has to generate more pressure to push blood through them to every part of your body. This is not a malfunction. This is compensation. The system is doing what it needs to do. The baseline pressure in an older body needs to be slightly higher to ensure that blood actually reaches the endpoints. Your kidneys, your brain, your retinas, especially when you're upright and gravity is working against the flow. Think of it like water pressure in an older building with old pipes. The infrastructure doesn't move the way new pipes do. You need more baseline pressure just to get the same effective flow to the top floor. This is why what looks like elevated blood pressure in an older adult is not automatically dangerous. In some individuals, in some circumstances, a reading of 140 or even 145 is the system working correctly, compensating for the structural reality of aging arteries. When you aggressively medicate that pressure down toward 120, you are not helping the system, you are fighting it. And the first organ to show the consequences is the brain. You're not imagining it, and it's not your fault. Now here's the second change that compounds this dramatically, because I know what some of you are thinking. You might be wondering, doesn't my body detect the drop and correct it? In a young person, yes, absolutely. Your blood vessels contain tiny pressure sensors called baroreceptors, located primarily in the walls of the aorta and the carotid arteries. When you stand up and blood pools downward under gravity, these sensors detect the pressure drop within milliseconds. They send urgent signals to your brain, speed up the heart rate, constrict the peripheral blood vessels, push pressure back up. The entire correction happens so fast that a healthy 30-year-old never notices it. Completely invisible, completely automatic. But baroreceptors become less sensitive with age. Their response time slows. The signal they send is weaker and delayed. So if your baseline blood pressure is already sitting low because you are on medication targeting 120 and you stand up, the pressure drops. The baroreceptors fire their slow, delayed response, and by the time the correction starts to kick in, 2 or 3 or 4 seconds have passed. Your brain has been running on insufficient pressure, and you've already reached for the wall, or you haven't reached for anything, because you didn't see it coming fast enough. Add to this a third factor, medication metabolism. Your liver and kidneys at 75 do not process medications at the same rate they did at 45. The half-life of many blood pressure drugs is effectively longer in an older body. A dose calibrated for a middle-aged patient can be substantially more potent in a senior, lingering longer, producing stronger effects, pushing pressure further down than the prescribing physician intended. You might be receiving the right medication in the right category, but the dose that's appropriate for your neighbor at 52 is too much for you at 76. And nobody is checking, because the sitting blood pressure in the office looks fine. These 3 factors, arterial stiffness, slowed baroreceptor response, and altered medication metabolism, work together. They don't add up, they multiply, and they produce a body that is fundamentally different from the population those blood pressure targets were designed for. Which brings us to number 2, the test that exposes this problem in 3 minutes, at home, tonight. Number 2, there is a 3-minute test that could tell you right now whether your medication is too strong. Most doctors are not doing it. Here is the reality of blood pressure monitoring in most medical practices. You come in for an appointment. You sit in the waiting room. You get called back. You sit in the exam room. The medical assistant wraps the cuff around your arm, takes a reading, writes it on the chart, and leaves. Your doctor comes in, sees the number, compares it to the target, and either continues or adjusts the prescription. That entire blood pressure assessment took 60 seconds and captured exactly one physiological state, you sitting still after resting. It captures nothing about what happens when you stand. The test is called orthostatic vital sign measurement. The name sounds technical, the test itself is not. You need a home blood pressure monitor, available at any pharmacy for approximately $30, sometimes less. Here is the exact protocol, step by step, so you can do this yourself. Lie flat on your bed or couch and rest for 5 full minutes. Not 3 minutes, 5. Let your cardiovascular system fully relax and stabilize. After 5 minutes, while you are still lying down, take your blood pressure and write down both numbers, the systolic, which is the top number, and the diastolic, the bottom. Write them down exactly, then stand up. Immediately, not after a minute, not after you've walked around, right away. Take your blood pressure again while you are standing. Write those numbers down. Now compare. If your systolic dropped by more than 20 points when you stood up, you have orthostatic hypotension. If your diastolic dropped by more than 10 points, same conclusion. This is a red flag. This means your blood pressure may be too low for your physiology when you're upright, which is most of your waking life. Let me make this concrete. Say your lying blood pressure is 124/78. Your doctor sees a number like that and is genuinely pleased. It's textbook, but you stand up and the reading is 97/60. That is a 27-point systolic drop. In the seconds it takes you to walk from the bedroom to the kitchen, your brain has been operating on inadequate perfusion. You may not feel dramatically dizzy every time. Some people don't. The symptom can be subtle. A slight softening of vision, a moment of mental blur, a sensation of needing to hold on even when you don't quite reach for anything. But the insufficiency is happening in your cardiovascular system, whether it produces obvious symptoms or not. And the risk is accumulating. Now you might be thinking, my doctor checks my blood pressure every time I come in. Wouldn't they have caught this? Almost certainly not. And here is why. When your doctor takes your blood pressure in the office, you have been sitting in a chair for several minutes. Your cardiovascular system has had time to equalize. The number on that cuff reflects your resting, seated physiology, not your standing physiology, which is where falls happen. What almost no physician is doing routinely, and the published research is explicit that they should be, especially in patients over 70 on antihypertensive medications, is the lying to standing measurement. It takes 3 minutes. It is not standard practice until it becomes standard practice. This is on you to do, and bring the results to your appointment, because the conversation that follows is one your doctor needs to have. Before I tell you about number 1, and number 1 is where the practical solution lives, I want to tell you about Margaret. Margaret is 77 years old. She lives in Phoenix, Arizona. She has been managing her blood pressure for about 8 years, first with 1 medication, then 2, then a slightly adjusted combination, when her numbers weren't quite reaching her doctor's target. She was diligent. She took her pills every morning at 7. She kept a little notebook with her readings. She did everything right. And by every conventional standard, her blood pressure management was a success. She was sitting consistently at about 124/76. Her doctor was pleased. Her chart looked exactly the way a well-managed hypertensive patient's chart is supposed to look. But Margaret started noticing something about 18 months ago. She'd get up from the dinner table after eating, and she'd need to hold on for a second, not fall. Just hold on. She'd stand up from the couch during a commercial break, and the room would tilt momentarily. She mentioned it to her doctor. Her doctor told her exactly what doctors tell patients in that situation. Slow down when you stand. It's just your blood vessels adjusting more slowly. It's normal at your age. Margaret nodded and accepted it. She's practical. She's not someone who catastrophizes over things she's been told are fine. And then one Tuesday afternoon in November, she stood up from the couch to answer her phone and woke up on the floor with her face against the coffee table. She hadn't fully lost consciousness, but she went down fast and hard. She fractured 2 ribs. She spent 4 days in the hospital, 3 weeks in a rehabilitation facility. And she told me, and I want you to hear this exactly as she said it, she told me, I knew something was wrong for over a year. Every time I stood up, I kept being told it was fine. Margaret's lying blood pressure, the morning after her fall, was 121/75. Her standing blood pressure, measured for the first time, was 89/58. A 32-point systolic drop. In 18 months of medical appointments, nobody had ever checked. That is what number 1 is about. That is what changes when you know this. Number 1. Your blood pressure target after 75 should be higher than you've been told. And here's exactly what the research says it should be. This is the part that sounds counterintuitive. This is the part that contradicts what you've read, what your doctor has told you, what's printed on the poster in the waiting room. And it is the part that the evidence most clearly and consistently supports. For adults aged 75 to 84, who are in relatively good functional health, the research points to a systolic blood pressure range of 135 to 145 as the optimal target, the range associated with the lowest mortality, the fewest falls, the best cognitive function, and the highest quality of life. Not 120, not even 130, higher than conventional guidelines recommend. For adults over 85, or for those who are frail regardless of age, people with multiple chronic conditions, limited mobility, or who live with significant medical complexity, a systolic range of 140 to 150 may be most appropriate. At this stage of life, preventing falls and maintaining the ability to live independently frequently takes priority over aggressive pressure reduction. The calculus has genuinely shifted. For adults between 65 and 74, who are active and without major complicating conditions, a range of 130 to 140 is reasonable, still accounting for the physiological realities of aging, even in those who are relatively young in this group. And on the diastolic side, the bottom number, which doesn't get nearly the attention it deserves, the research suggests it should stay above 65, ideally maintaining between 70 and 85. Here's why that bottom number matters more than most people realize. During the phase of the heartbeat, when the heart muscle is relaxing and refilling, the diastole, blood flow to the heart muscle itself, depends on adequate diastolic pressure. If the bottom number is consistently below 60, your heart muscle may not be receiving adequate blood flow during its own rest phase. That creates risk on a completely separate track from the systolic concerns we've been discussing. If your diastolic is consistently below 60, that warrants a specific conversation with your physician, regardless of what the systolic is doing. Now here is the word I want you to hold on to: individualized. Your target should not be the same number as the target for a 52-year-old who walked past the blood pressure guidelines chart on the wall. Your target should account for your specific age, the stiffness of your specific arteries, the speed of your specific baroreceptor response, your other medications, and how your kidneys and liver are metabolizing them, your functional status, your history of falls, your other diagnoses. Are you active? Do you have diabetes or a prior cardiac event? What does your kidney function look like? All of these variables change the calculation, and none of them are captured in the universal guideline that says get to 120 over 80. Consider two people who are both 81 years old, same age, same number on the blood pressure cuff, 158 over 88 for both of them. First person, living independently but managing several conditions: mild heart failure, chronic kidney disease at stage 3, significant osteoarthritis in both knees that affects mobility and balance. Second person, active, healthy, plays golf twice a week, no significant medical conditions. Same number, same age, completely different bodies, completely different risk profiles, and what should be completely different clinical approaches. For the first person, aggressively medicating toward 120 carries serious danger. It could produce orthostatic drops, large enough to cause falls. With heart failure and kidney disease, lower pressure can worsen kidney function. The kidneys need adequate perfusion pressure to filter blood properly. And with severe osteoarthritis affecting balance and joint integrity, a fall would not be a minor event. A more thoughtful approach for this person might be careful lifestyle modifications first, and if medication is necessary, a conservative single low dose with frequent monitoring, accepting a target of perhaps 140 to 145 systolic, rather than pushing aggressively downward. For the second person, the healthy 81-year-old golfer, 158 over 88, probably does warrant some intervention. But the target doesn't need to be 120, and the approach doesn't need to be aggressive. The research supports a higher ceiling for this individual. The right target might be 138 or 142. Reached gradually, with careful attention to how they feel when they stand and move. Same numbers, different people, different medicine. Treating the patient, not the number. That distinction is the whole story. You might be wondering why. If this research is this clear and this consistent, your doctor hasn't brought it up. It's a fair question. It's not a criticism. It's important context. Medical guidelines do not change quickly. The large clinical trials that established 120 as the gold standard took years to conduct and years to publish. The research specifically focusing on older populations, research like the JAMA internal medicine study I described, is relatively recent. It takes additional years for new findings to be reviewed, incorporated into updated guidelines, and then actually adopted into daily clinical practice. The pipeline from research to exam room is slow. Many physicians are still operating from guidelines that were written before this data existed. There's a second factor. For decades, the core message in cardiovascular medicine has been that lower blood pressure saves lives. That message was drilled in during medical training. It became reflex. It became assumption. Shifting from that reflex to a more nuanced approach, one that says lower is better up to a point. But below that point, in older patients, we may actually be doing harm, requires doctors to think critically about each individual patient rather than applying a universal rule. In a 15-minute appointment with a patient managing 5 conditions and taking 8 medications, that kind of individualized recalibration is genuinely difficult. The gap between what the research shows and what happens in practice is not malice, it's system pressure. But the cost of that gap falls on patients, not on systems. This is why your active involvement in your own care matters so much. Here is exactly what I want you to do, starting today. If you are over 70 and on blood pressure medication, purchase a home blood pressure monitor if you don't already have one. Check your pressure at the same time every morning and every evening for 2 consecutive weeks. Log every single reading, date, time, both numbers. This gives you a true average that is far more clinically meaningful than the single reading captured during an office visit. Bring that log to your next appointment. Perform the orthostatic test I described. Lie down for 5 minutes, take the reading, stand immediately, take the reading again. If the systolic drops more than 20 points, write that number down. That data belongs in your appointment. Assess your symptoms honestly and completely. Dizziness when standing, fatigue that feels disproportionate to your activity level, mental fog in the mornings that doesn't clear quickly, difficulty concentrating when you've had adequate sleep. These are not just aging. They deserve to be documented and discussed. They may be the clearest signals your body is giving you that something about your current medication regimen needs to change. When you see your doctor, do not accept the universal target without a direct conversation. Ask specifically, given my age, my other conditions, and my functional status, what is the right target for me? Frame it as a genuine question, not a challenge. Bring your home readings. Bring your orthostatic measurements. You are not there to argue with your physician. You are there to give them information they need and don't currently have, and to invite a conversation that the current system is not consistently prompting on its own. If you are experiencing side effects from your blood pressure medications, the dizziness, the fatigue, the moments of grabbing for things, say so directly and clearly at every appointment, not in passing, not as a footnote. These are not symptoms you have to accept as the price of treatment. Doses can be adjusted. Medications can be changed or switched to formulations that behave differently in an older body. Targets can be reconsidered. The conversation is not closed just because a number on a chart looks good. Think back to where you were at the beginning of this video. That moment this morning, the nightstand, the room tilting, the brief grab and recovery. You told yourself it was nothing. You moved on. You now know what it is and why it happens. You know what 3 specific physiological changes make your cardiovascular system different from the one those guidelines were written for. You know what the research actually says about the blood pressure range associated with the longest survival and best quality of life in adults over 75. You know how to test yourself tonight in 3 minutes with a $30 monitor. You know what numbers to look for and what they mean. You know the questions to take to your next appointment and the data to bring with you. You are no longer walking into that exam room without a map. And Margaret, who spent 18 months being told her dizziness was normal, who fractured 2 ribs on a Tuesday afternoon in November because nobody had ever measured her standing blood pressure. Margaret, whose doctor finally adjusted her regimen after the fall, who now has a target of 138 to 142 systolic, who has been monitoring carefully for 14 months since. Margaret told me recently that she walks her neighborhood in the mornings, 30 minutes most days. She said, "I don't grab for things anymore." Not a dramatic statement, just a fact. The kind of fact that a 77-year-old woman should not have had to earn through a fractured rib and 3 weeks in a rehab facility. You deserved to know this sooner. Now you do. And hey, if you made it all the way here, please subscribe to this channel if you haven't already. Hit the like button to let me know this was worth your time, and leave a comment below. Tell me what country you're watching from. Seriously, I read every single one, and it means a lot to see how far this community reaches. You know what the problem is with diabetes and high blood sugar. Most people find out way too late, and by the time they do, they have no idea where to even start. That's why I decided to create a free guide. It's called the Glucose Paradox, and inside, you'll find everything you wish you'd known sooner. I'll explain how blood sugar actually works, and why your body sometimes reacts the exact opposite way you'd expect. That's why it's called a paradox. I've also included concrete habits you can start changing right now, even if you know zero about nutrition or medicine. It's free. You can download it in a second, and it might be the single most useful thing you do for your health today. Just click the link in the description to head to the site, drop your email, and get the guide sent straight to you. Don't put this off. This video is for educational and informational purposes only, and is not intended as medical advice. Blood pressure management should be individualized based on your complete medical history, current health status, and other factors. Never adjust or discontinue medications without consulting your healthcare provider. Always consult with a qualified healthcare provider before making changes to your treatment.